I'm Diane Schonsbach. I'm the director of the Hamilton Project, and let me introduce our panel here today. Seated to my left is David Cutler, who's the Otto Eckstein Professor of Applied Economics at Harvard. He served in the Clinton administration and served in key roles in healthcare policy. His most recent book is The Quality Cure: How Focusing on Healthcare Quality Can Save Your Life and Lower Spending Too. Next to David is Mark McClellan. He's the Robert Margolis Professor of Business Medicine and Policy and the director of the Duke Margolis Center for Health Policy at Duke University. He was formerly the administrator for the Centers for Medicaid and Medicare Services, and formerly was the commissioner of the Food and Drug Administration. Next to Mark is Angus Deaton, the Dwight D. Eisenhower Professor of International Affairs and Professor of Economics and International Affairs at the Woodrow Wilson School and at Princeton University. As Bob mentioned, he won the 2015 Nobel Prize in Economics for his work on consumption, poverty, and welfare. And this is a Hamilton Project first. He was recently named a Knight Bachelor by Queen Elizabeth II of England, which I think is extremely cool. Next to Angus is Jim Marks. He's the Executive Vice President of the Robert Wood Johnson Foundation. He was trained as a pediatrician and in public health. He's published extensively in the scientific literature on public health. And next to Jim is Gary Burtless, the John C. and Nancy D. Whitehead Chair and Senior Fellow here at Brookings. He's also published widely in public finance, aging, labor markets, social insurance. I could go on and on. So now that you've met the panel, let me just give you one sort of order of business, a little bit of housekeeping. Underneath your chairs, there are index cards. The way we like to do the question and answer time here at the Hamilton Project is when you've got a question, you can write it down on that card. Our staff will be going up and down the aisles collecting those, and then they'll bring them up to me, and then I'll be able to ask the questions. We've set aside the last, I think, 15 or 20 minutes to cover your questions. So write those down and pass them along as they come to you, and bonus points for writing neatly, because it's hard to read. I might need to start bringing my glasses, which is another hazard of middle age, I suppose. So Angus, let me start with you. So you were careful to explain to me earlier that we want to really keep distinct the life expectancy and mortality, and describe this a little bit, but tell us a little more. How are life expectancy and mortality different?
Well, one sounds much cheerier than the other, which is, like you said, we were very depressed. It's nice to think about life expectancy. It's not so nice to think about death. But I want to argue that I think there's a lot of danger of people getting confused here. I think people like life expectancy much better than they like to think about mortality. And I think the reason for that is that they think they understand it. Unfortunately, they don't. And life expectancy is a very, very, very odd concept. Life expectancy is, people think what it means is, if you take someone at 40 and you say, what's the life expectancy? It's 40. It's the number of years you can expect them to live. And typically that's not true. Because what life expectancy is, it calculates how many years you would live if today's mortality rates were to remain in force. Today's age-specific mortality rates were to remain in force for the rest of your life. Now, the reason we're all here today is because those age-specific mortality rates are changing. So if you calculate life expectancy at birth now, or you calculate life expectancy at 40 now, you're going to get it wrong. And you're almost going to certainly be too optimistic about it, because those mortality rates are getting worse. Or at least that's what we've been talking about today. Now, of course, next year they may turn around and so on. But, we've lived in an age in which life expectancy at birth typically understated the number of years you could expect to live, because mortality rates were improving all the time. If we now move into this behavioral world in which bad behaviors or difficult behaviors are causing us to die sooner, mortality rates to go up, then we're going to be living in a world in which the life expectancy measures we look at are actually too optimistic. So I'm cheering you up in the wrong direction, I'm afraid. The other thing which Anne mentioned, but is worth emphasizing again, is life expectancy. The other reason people like it is because there's one mortality rate for each age, which is, there's a probability of death at each age, And so you have to carry around 100 of these things, and it'd be much easier if you just carry around one number like life expectancy. So it's sort of like an index number problem. But saying that life expectancy is going down because mortality is going up is sort of like saying the CPI has gone up because the price of peas had gone up. It's mortality rates at a specific age, and you have to combine them. And life expectancy combines them in a very, very strange way, which is it gives all the weight to the beginning of the calculations. So if you're taking life expectancy at birth, it depends incredibly heavily on what's happening to kids and hardly at all on what's happening to old people. And life expectancy at 40, it depends a lot on what's happening when you're 40 or 41 and not so much when you're in old age. But for a lot of the policy issues we're interested in, it's old age that really matters about these things. And so that's another reason for sort of switching, I think, to mortality rates. Let me say one other thing. We like to think about changing patterns of life expectancy, by different education groups or by different income groups or by different parts of the country. I actually think it used to be 20 or 30 years ago when I first started thinking about health, people didn't think about these disparities very much or changing patterns by different groups. I think one of the reasons that what Ann and I found had not been noticed before was because people were paying so much attention to inequalities between different groups and not enough attention to people actually dying. So let me emphasize that one way. I mean, you can imagine a world in which life expectancy was going up for all groups, but it's going up much faster for some groups than other groups. And that might really worry you, and it's certainly something we should pay attention to. The CDC in recent years has paid a lot of attention, rightly, to the fact that black mortality rates are falling much more rapidly than white mortality rates, so the black-white gap is falling, and that's just terrific. But in the same reports, they didn't seem to notice that the reason the black-white gap was falling was because white people's rates were going up, right? So this is just not a question of relative deprivation of different groups in a world that's getting better. This is a world in which people are dying who should not be dying. I mean, that one of the last slides Anne showed, that's the one that 165,000 people would arguably be alive today if opioids had never been invented. I mean, those are people who are dead because of these prescription legal drugs, heroin in a pill. And that's just the opioids. So I think focusing on mortality is very important, and we should not make life easy for ourselves by focusing on life expectancy. Thanks very much.
Thanks. I was going to come back to you for one more question
Okay.
before going to the rest of it. So Anne talked a little bit about some of the hypotheses that you have, but I wondered if you could expand a little bit more on those and also just talk about how big these magnitudes are.
Well, I mean, the numbers are, they're big numbers. I mean, any time a mortality rate turns around, you're not talking about just a bubble, but you're talking about, something. And, we've all grown used to this fact that mortality's been falling for all of us in all age groups. And, the little things come along. But the number of people who have died because of this is sort of comparable to the number of people who've died of HIV/AIDS. I mean, you're talking about in the United States, not worldwide. I think I don't have much to add what Anne said. I think teasing out the causality here is really hard because there are too many things going on at the same time. There's been a lot of bad economic things happen to these groups. The Washington Post did this terrific thing and correlated our data with the people who are voting for Donald Trump, and a very, very close relationship there at all. So these people are upset. They feel they haven't seen much economic growth. They haven't seen any economic growth for a really long time. Their children's education may be collapsing. I think they're seeing other racial groups, blacks and Hispanics, doing relatively well. And they feel they're not getting any progress at all. They're seeing bankers and other people. I mean, I think this is in the sense in which inequality has been a problem, that these people have seen very little for themselves for a very long time, and yet they're seeing other people who are doing extraordinarily well. Now, I mean, all of this sounds great when I say it, but I mean, that's different from having a much more precise scientific sense of whether the patterns match that. And remember, too, that in Europe, there's a lot of people who faced a lot of economic distress. A lot of jobs that used to be in Europe that are now in Vietnam or in Cambodia or something, just as they are in the US. This is not happening in Europe, or nothing like the same scale. And we, I think, find it hard not to implicate the opioid epidemic as part of that.
Mark, I'm going to turn to you. Can you talk about some of the policy implications for health policy and the healthcare delivery system in particular?
Yeah, Diane, I want to talk about healthcare and its role in this. And just as Angus asked you to think differently about life expectancy, I want to ask you to think differently about the role of healthcare in population health, and maybe be a little bit more optimistic. I don't know. We'll see. It's a pretty tough afternoon. The background paper talks a lot about the huge improvements in life expectancy with declines in age-specific mortality rates at just about every age over the past century, and it highlights a lot of the role that healthcare may have had in that, declining infections, declining rates from heart disease, and so forth. What's important to know behind those numbers, though, is that most of those improvements were not due to breakthroughs in medical technologies, but due to other factors. So a lot of the decline in mortality rates from infections happened before the antibiotics came along, or due to things like cleaner water, more sanitary food, better dietary habits, less stressful and physically straining environments that came along with economic development and other things kind of beyond healthcare. In more recent years, we've seen some declines in age-specific mortality as well, where healthcare may have played a role. Some declines in cancer, continuing declines in heart disease, though there too, behavioral factors, things like smoking rates, which are still playing through, as Anne highlighted in her remarks, still playing through in kind of higher rates than we'd like to see for women in cardiovascular disease, is still an issue. So medical care has been important, but it hasn't been the main driver of these trends. And Angus talked about some of the concerns about the opioid epidemic and crisis related to that. I kind of think that even if we did have more success in prescription drug monitoring programs and sort of very medically focused approaches there too, traditional medical focus there too, I'm not sure that's going to reverse the trends that we've seen. And Anne's own data showed these rates of increase in deaths of despair for these age groups going back to the early 1990s. So what might make more of a difference? Well, I think it's time to rethink the way that we view healthcare policies more generally. There has been a substantial increase in healthcare spending that's gone along with these trends over past decades. It's clearly had, I think, a favorable impact on the decline in mortality rates for younger children, for infants, and for minority populations. But despite all of that, these overall differentials and these overall age-related risks are going in the wrong direction in some cases. And even though we've had a big expansion of health insurance coverage in this country, I think, Gary, some of your work showed that this was the biggest redistribution in terms of economic impact to lower-income Americans in 40, 50 years. I don't think that by itself is going to change the trends that we've seen. What are some hopeful signs in healthcare? Well, one is that there are some reforms being taken in healthcare systems in places around the country now that are making more of a difference in addressing some of these root causes of health care declines and increased mortality. Some of these examples in places like Hennepin County, Minnesota, in Denver, where Denver Health is providing some remarkable treatments for substance abuse and other health problems, in new kinds of programs for people who are eligible for Medicare and Medicaid, including some of these vulnerable populations. They're doing it by changing the way that they deliver health care in a more fundamental way. So not focusing so much on treating the health problems when they occur, but trying to intervene earlier by going at root causes. For example, a program in New Jersey, in Camden, New Jersey, is focusing on hot spotting. And in this effort, they've tried to look at the root causes that were leading to hospitalizations and emergency room visits and accounting for a lot of healthcare costs. They found that in most cases there were underlying pressures that were outside of traditional medical care, things like underlying behavioral or substance abuse problems, things like not having a home or having social or physical stresses at home, or not having a job. And by shifting resources to more personalized, supportive approaches that focus on these root causes, they've been able to both reduce healthcare costs and reduce some of the underlying risk factors that I think are related to the kinds of trends that Angus and Ann were describing. The problem is it's almost impossible to support those kinds of programs in the traditional way that we've financed and delivered healthcare. All of the programs that I mentioned have had a vision for a new way of delivering care that's been led by healthcare providers working with social service systems and trying to address these underlying issues in new ways. But they've been accompanied by different ways of financing healthcare, not just focusing on paying for the medical treatments, but more global payments where financing streams for Medicaid might be combined with financing streams locally for substance abuse or for educational programs, and with the healthcare providers involved taking on overall accountability, not having open-ended fee-for-service payments for traditional medical care, but taking on more accountability in return for having more flexibility in how they're supporting the individuals who are facing these challenges in their lives. And that kind of change, I think, can lead to both steps in the healthcare system to address some of the challenges that we've talked about today, and also steps to bring down overall healthcare costs. And that's a second way in which we need to rethink some of these policy issues. By spending more on healthcare, we've undoubtedly increased access to a lot of traditional health services. But for just about every state in the country, and certainly for the federal government, the increased spending on healthcare has been accompanied by reductions or tightening of spending in programs like pre-K education, social service interventions to help build more of a community network and supports for individuals who are struggling in their lives. And that kind of shift has made it more difficult to address the kinds of problems that Ann and Angus have talked about. So for two reasons, healthcare reform, I think, is fundamentally important to addressing these trends, even though we do need to get some more evidence. One is to reform healthcare to put a much greater focus on how healthcare systems can and do impact the lives of especially vulnerable populations. And second is to bring down overall healthcare costs so that we have more resources that can go into these other very important programs to address some of the social challenges that we've talked about today.
Undoubtedly, we'll be talking more about that on the panel. David Cutler, can I turn to you? You've done some fascinating recent work on area-based differences. In fact, we highlight some of that work in the framing paper. So can you talk about what are some of the characteristics of places that have good outcomes for mortality rates?
Yes, I'm happy to. I'm always sad though when I have to be the optimistic person. So I'll try and do my best. I've been doing work, as you point out in the background paper, on life expectancy, which, with apologies to Angus, life expectancy both nationally and across areas. Let me just give you just a brief taste for what we've done. We know people's income because we have access to IRS data on incomes for people over roughly a 15-year period from the late 1990s through just a year or two ago. So about 1.4 billion observations. And the IRS needs to know if people are alive or not to know whether to expect an income tax return from them. So they actually get it from the Social Security Administration. So we have matched data on individuals where we can look at their income and then their mortality rate. And so we can see for 52-year-old men what is the income and mortality, and we sort of put people in buckets, into 100 percentile buckets, where we know exactly what percentile of the distribution you're in and mortality rates at each age. And so we then have those. We can then string them together over time to say someone who started at age 40 in a particular income percentile, what do we estimate their life expectancy would be? So in addition to being able to tell you what Ann showed you about differences a little bit by education and certainly by race and ethnicity, we can also look at the income level, which turns out to be extremely important here. So first, before giving you the good news, I'll give you some of the bad news. What this chart shows you is by 100 percentiles, by single percentiles of the income distribution, what is life expectancy at age 40. And in each, the blue line is for men and the red line is for women, so women live longer than men at all incomes. And the lines are upward sloping. And so that is higher income people tend to live longer. It's not necessarily causal, but it's certainly correlational. There's nothing new about showing this chart. That is, we've known this chart for a while. The couple things that are of interest here. One is there's no income above which higher income is not associated with longer life. So if you thought like, at $500,000 a year, earning $600,000 a year can't possibly be associated with living longer, the answer to that is you're incorrect. And similarly, if you thought that, below some income there had to be a safety net that supports people and so they don't live shorter, the answer to that is you're incorrect also. And in fact, the differences here are big. So the difference in life expectancy between the top and the bottom is about 10 years for women and about 15 years for men. To give you a couple of ways to think about that, 10 years is roughly the difference between smoking and not smoking. So it's as if every low-income woman smoked and no high-income women smoked. And just put it by another metric, if we were to cure cancer in the US, average life expectancy would increase by about 3 years. So these gaps are between 3 and 5 times the impact on the US population of curing cancer. So we sort of have that as a backdrop. We can then, because the IRS does know where you live, or at least where 1040s get sent to you, or other forms, we can actually figure out what's happening in different areas of the country. And somewhat interestingly, the change in mortality rates, particularly, say, for the bottom quartile of the population, which is what we're looking at here, varies actually quite a lot across the country. So some areas of the country, so this is sort of the good news to the extent that Diane, I can give you some good news, which is that it's not an immutable fact that high-income people live longer and low-income people don't or live less long. There are areas of the country where low-income people seem to be living longer, and then there are areas of the country which are really just very, very poor. Very, very bad for low-income people. The areas where low-income people live longer are in California, and then particularly throughout parts of the Northeast down a little bit the Atlantic seaboard. The middle of the country is areas where low-income people are living less long. It's not all just growing areas. So for example, you can see some areas that are not growing rapidly, which are having increases in life expectancy for low-income populations, and some areas such as Florida that are growing quite rapidly, where low-income people are actually doing very poorly in terms of their health. Just to give you an example of how hard this is to predict, I want to give the audience a quiz, which is, which of these two cities has a better health profile for the low-income population? Tampa, Florida, or Birmingham, Alabama?
Gotta be Tampa.
Birmingham, Alabama is, of course, the correct answer. That is, life expectancy is high and getting higher in Birmingham compared to Tampa, Florida. So the question is sort of, what are these associated with? That is, what do you learn from this? These are clearly associated with changes in behaviors, which goes back to a point that both Anne and Angus raised, which is that these, and Mark McClellan did as well, which is if you sort of overlay on this maps of smoking and obesity and exercise and so on, they would look very close to this. There's not a lot else in terms of what you think of as traditional medical care that these are related to. It turns out not to be extraordinarily related to the share of people with insurance coverage or other kinds of things. What it does seem to be related to, in addition to the behavioral components, is what I think of as a sort of upper middle class area. So if you look at the correlates between various factors, various socioeconomic factors, and life expectancy for the low-income population, it's highly correlated with the percent of the population that's foreign-born. By the way, that's controlling as best we can for the ethnic mix within the area. So it's not just that foreign-born people live longer than native-born people. It's correlated very strongly with median house prices, with the density of population, and with the share of college graduates in the area. And it's correlated quite strongly and positively with local government spending. So to put it another way, areas where low-income people live a long time include New York, San Francisco, Los Angeles. They're not particularly homogeneous areas. They're not areas where rich and poor live in the same neighborhoods, but they're areas where there's a kind of robust middle to upper middle class. And at least, I'm not saying why that's the case, but there's at least something about that kind of area which turns out to be very healthy. At a minimum, what this suggests is that we should be able to learn from the darker green areas and try and transport that as best we can to the upper, to the more reddish orangish areas, and to try and see what has been relatively more successful that we can copy.
Thanks. Can you pass that down to Jim? So, Jim, turning to you, given your work at the Robert Johnson Foundation, we were hoping you could talk about, should we be looking for some sort of a longer-term solution here? How should we be thinking about health investments across the entire life course contributing to mortality?
Thanks, Diane. Well, we're going to talk a lot about the deaths of despair, and there's been a bit of a panel of discouragement. I'm going to talk a little bit about where I think there are some opportunities, but I want to sort of summarize in broad brushstrokes where I think we are. And so this is from a National Academy of Medicine report that's called Shorter Lives and Poorer Health. And what this is the ranking of the U.S. men and women for 17 countries by remaining life expectancy at each age. As you can see, we are dead last, or maybe second last, at every age up to about 70. And then we really zoom up so that by 95, we have the best life expectancy in the world. That is, after most of us are already dead, we live the longest. And it suggests that our health care, when people really need it, is actually quite good. But it's the earlier ages where we've got to look for solutions. Now, this is one that's specifically at women. And this is a little different, but picks up on what Ann said. This is the likelihood of a baby girl living to age 50. In 1980, we were doing very badly, and then rapidly got worse. So we were second last in 1980, and now, by the early 2000s, we are further from second last than second last is from first. So you might say, where do we have to put our energies? We have to put them at the younger ages. And that's where I want to talk about briefly. I think the key points there are, we are seeing biologic science and social circumstances and their implications start to come together. And I'm going to touch on this just a little bit. We know that children born in poverty and the stresses they experience in those households affects their brain development, perhaps permanently. There is some question of how there's plasticity at the earlier ages. There's plasticity in the teenage years especially. But that's where there could be great opportunity for improvement. The second part of it is there are, in fact, some randomized trials of children that were in good quality child care, whether it's pre-K or earlier, and then followed the longest up until about age 40. The most recent paper followed a different group up to age 25. They found that those children that got good quality child care at the youngest ages, in fact, did better. They did better in that they were more likely to graduate from high school, more likely to graduate from college, less likely to have substance abuse. Huge effects. And the parts that correlated the best were how they interacted with others. That is, could they share with others well? Could they show empathy and care for others and their feelings? The non-cognitive skills turned out to be the most effective. And the most recent study asked kindergarten teachers to rate their children on an 8-point scale. This was done 25 years ago. Highest to lowest, a fourth-fold difference in college, attainment by age 25. Quite enormous. We've seen in other areas that besides the building of interpersonal skills, there was a randomized trial where low-income families were given vouchers that allowed them to move to higher-income neighborhoods. This picks up on what David said. And in fact, those children did, and the families did better just by moving. Lower rates of diabetes, for example. So we're finding that these connections between the social circumstances and the biologic are supporting each other. So I would argue that if we are serious about improving our life expectancy, the places we ought to be making our investment are in young children, because they'll do better with relatively short-term interventions. In fact, there's other randomized data on nurse home visiting when young mothers, the low-income young mothers, get nurses to visit them. It turns out it affects, up to age 2, the visits. It affects lowers the child abuse rates. It increases the likelihood that the children would do well in school, and lowers the likelihood that those children up into their 20s lowers the likelihood that they'll be involved with juvenile justice. So we have interventions that can work, but they may not be thought of as, Mark was saying, classically in healthcare, and they may not be ones that we would have thought of because of the age effects. The other part that those studies have shown, especially the nurse home visiting, but a few others, is that the mothers do better. So you have, if our diagnosis is deaths of despair, we've got to find ways that we provide treatment that is hope. And helping mothers with their children, giving them good quality care, daycare, so that they can go back to work or go improve their education, those things, I would argue, are probably our best shot at where we should be making more investment as a nation. That doesn't mean the opioid epidemic is not serious. It is. But if right now I see that epidemic and others, substance abuse, as symptoms more than root causes.
Thanks. And Gary, turning to you, I know you want to talk about a lot of these pieces, but I'm going to start by asking you about this important recent work that you've done, thinking about the impacts of these trends for Social Security. I know the recent Institute of Medicine panel built off of your important background research on that. So how should we be thinking about Social Security reforms in light of the divergence in life expectancy?
Well, before turning to those policy conclusions, it's probably useful to tell you something about the work that my colleagues Barry Bosworth and Con Zhang and I did. This research was partly supported by the Social Security Administration and partly supported by the Sloan Foundation. What we wanted to do was estimate the statistical link between people's earnings in the middle of their life and later longevity. At what ages did people die later on? And over time, over a 30-year period, how fast was the reduction in mortality at given ages, depending on whether your mid-career earnings was high or low. So we had information on 85,000 people in one of our samples and about 30,000 people in another sample, and we could follow these people for up to 30 years and see when they died, and their death records were matched to their Social Security earnings records and to a fairly sizable interview questionnaire about their behavior in midlife. What did we find? Well, our results are prefigured on the handout, this framing paper. There's a picture, figure 3 on page 4 of that it's not, those aren't our results. Those are the results of the National Academy of Sciences. But broadly, they show what we find too. We find that mortality rate declines after age 50 have been noticeably fast for high-income Americans, whether men or women. They have been practically non-existent for people near the bottom of the income distribution. And this is particularly true for women, where we found in the bottom 1/10 of the mid-career income distribution, we found no improvement over a 30-year period in their mortality rates, whereas there were fairly sizable gains in the mortality rates of more affluent women and more affluent men. So what do these results mean for Social Security? Well, before touching on that, I should say, had we known of Ann's and Angus's research results before we lost our access to these confidential government records, we would have done our research somewhat differently. We would have examined these trends as best we could within racial and ethnic groups. What we noticed was once you examined trends by income or by educational attainment, the mortality rate gaps between different ethnicities shrank dramatically. So just including people's mid-career incomes did account for a lot of the ethnic differences. But remember what their results showed, that there has been much faster progress in Hispanic Americans and in African Americans compared with white Americans, at least in the middle of life. And we could have, had we known this result, we certainly would have organized our research differently. But anyway, what did we find that is relevant to thinking about Social Security policy? Well, affluent Americans continue to see very rapid gains in life expectancy. So I imagine for most people sitting in this room, actually, the news is cheerful we're giving you. It's not cheerless, it's cheerful, because most of you are probably in the parts of the income distribution that have seen very remarkable progress. David's research with Raj Chetty and co-authors shows exactly the same things. In the 15 years covered by their research findings, there was very rapid gains in mortality rate reductions among the most affluent Americans. We find the same thing if we are looking at people's mid-career incomes, mid-career earnings. Current law in the United States is currently reducing the amount of Social Security benefits you can claim if you claim them at 62 or 65 or 67.
Are we just repositioning? You're a hand talker, so am I.
Because the retirement age for full benefits has been going up in the United States, and that has the effect of reducing the available benefits to you if you claim them at 62 or if you claim them at 65. And on average, of course, Americans have been living longer, so the fact that you have to wait longer for a full Social Security check seems consistent with the fact that you are in better health at later ages. But Americans at the bottom of the income distribution, on average, have not been seeing any improvement in their expected lifespans at age 50 or at age 60. So that means that if we cut the benefits that they can obtain at age 62 or 65 or 67 by, let's say, 8% or 10%, we are cutting their lifetime benefits by exactly the same percentage. That's not true for people in my position in the income distribution. Compensating me for the fact that I have to wait longer to get a full Social Security pension is the fact that I can expect to live more years past age 65 than I was in the past. Remember, your lifetime benefits are simply the number of months that you're going to receive benefits times the monthly benefit you receive. Social Security's benefit formula for the monthly check is very redistributive in the interest of low-income Americans, low-income contributors to Social Security. But that redistribution in the monthly benefit formula is being gradually offset by a rising gap in life expectancy at age 65 between people who are affluent in the middle of their life compared with people who are low income in the middle of their life. So it strikes me that everything else we know about the situation of Social Security and its reform, adding this fact about the growing discrepancy, the growing gap in life expectancy between low and high income contributors to Social Security should push you in the direction of thinking we should preserve benefits, the real level of benefits for lower income Americans at age 62, at age 65, at age 67, because they, unlike their more affluent compatriots, are not sharing in the gains in life expectancy that the rest of us are enjoying.
Thanks. So don't forget to write your questions. They're going up and down the aisles. But I'm going to open it up to the whole panel. So I think my next question is, okay, there's tons and tons of unknowns here, as we've seen, and I think we're going to be talking about, unpacking these results for at least a decade, probably longer. Should we wait 10 years before we think about policy solutions, or what are we ready to say in terms of we need to do some acting here? Who's ready for a policy solution, or do you just say, let's wait till everybody just dies of old age in the first place?
It's too much of a softball, Diane.
No.
You have to act. It's sort of like if you have cancer and you go to
But what do you want to
if
do?
you go to an oncologist, he's got to act, or she,
Yeah.
with what they know now, even though they know more research is coming.
So what do we know enough
So
of?
I've
Yeah.
suggested the areas of support for young families and their children as an area where the evidence, I think, is strong, and some might say it's going to take too long, and there's certainly going to have to be short-term adjustments for the cost issues in other areas. But I think as far as long-term, that's where I would place my bet.
Same with you,
And
Mark?
I've suggested already some shifts in the way that we
Right.
think about healthcare. So making healthcare spending.
How likely do you think that is?
Well, I think there actually is a fair amount of bipartisan support between the big surface issues like the ACA for changing the way that healthcare payments work, and I think for giving people more control over how healthcare resources are used on their behalf. So less payments that are tied to just getting treatment in the emergency room or in the hospital when you have a complication from a chronic disease or an overdose, and more shifts in payment towards the treatments and out-of-hospital services, non-traditional medical services, things are like what Jim was talking about, that can prevent it. Now, those typically are too expensive to provide, just in the same way we've been doing it, adding in more and more spending for more and more covered services. So the most promising ways to do it have been about shifting the payments from paying for specific services towards paying on behalf of what people need most. That means more accountability for healthcare providers in terms of keeping overall costs down as they make these shifts in services, and also maybe more control for individuals about how they get resources on their behalf. And many of these programs giving lower income people more control over getting assistive services at home or other things like that can substitute for a lot of spending on healthcare.
Angus.
Yeah, I'm very much with Jim about the kids. I'm with Mark on the different ways of paying for things too. But one of the troubles about thinking about the kids, and I really do think we need to do something about the kids and focus on better education, so that I think one of the causes for despair of these people would certainly make me despair. If my life hasn't worked out as I thought it would, that's bad enough. But if I thought that was going to be the same for my kids, that would, I think, make it an order of magnitude worse. So I think it benefits not just the kids, but also the parents to do something like that. On the other hand, you have to be conscious of what you're doing if you do that, which is you're sort of saying, okay, we're giving up on this generation, and we're just saying, okay, there's nothing we can do for you. We're going to write you off. We'll try to do something better about your kids. So I think we've got to do something for this generation. And the immediate thing that we can do, I think, is we've got to explore treatment options and better treatment options, and make it easier for doctors to do things that don't involve the cheap and easy, and in the long run, neither cheap nor easy solution of prescribing opioids for people in pain, for example. Treating addiction is incredibly hard, and we need to know a lot more about that. But finally, I'd like to broaden this a little bit. Maybe I'm not supposed to do this, but I mean, I think this class, these people in the middle, these relatively uneducated people, also feel that they have a complete lack of voice in this society. I don't think they think that either political party is listening to them at all, or that they can have any effect on either. 40 years ago, they would have been a natural constituency for the Democrats. They've become a natural constituency for the Republicans. Neither party is offering anything for them. They're turning to people who are offering solutions that will not solve anything at all. But, I think you have to ask as to why these people think Congress is so unresponsive to them, why indeed it is so unresponsive to them. And I think you have to put issues like campaign finance reform on the table as making it possible for these people to re-enter civic participation in a way that they've really lost over the last 30 or 40 years.
I'll go to David and then to Gary.
So I in my mind, distinguish between technological solutions and social solutions. And so technological solutions we tend to be better at, of a couple different kinds. One are medical interventions, and I think Mark was very well laying out some of the ways that we could use the medical system to improve the health of people before it's an absolute emergency. The other example of technological solutions are in public health when we set our mind to it. So if I'd have told you 40 years ago that Americans would drive faster and more miles than they drove, and yet automobile deaths would plummet, you would have told me I was nuts. And if I'd have told you 50 years ago that smoking rates would fall in half, and that half the people who ever smoked would have quit, you'd tell me I was nuts. But sort of we come up with kind of technological solutions of the both medical care and the public health measure to public health dimensions to these sorts of problems. I think where we have a hard time is if you take this sort of Anne and Angus view that, no, really what this really is all about despair just seeping out in one form or another. And so if you make it harder to kill yourself driving, people will find some other way to do harm to themselves. And if you make cigarettes harder to get, well, there's always alcohol. And if you make alcohol harder to get, well, there's always some form of heroin, and so on down the list, and you'll never sort of get through, and we'll always worry about the next crisis after the next one. If you have that, then you come back to where Angus was, which is, what is the social issue that, how does one address the underlying economics or civics or social aspects of that? I asked my favorite director of the Hamilton Project what we know about how to improve the economic status of people who are not at the bottom, where you could think about the minimum wage or the earned income tax credit or whatever, but people who are above that, to the middle of the distribution, and really help them out a lot. And what I got back when I asked was, we're not exactly sure exactly what to do, and there are some ideas, but there's nothing you can kind of lay out that would.
And I should add to this, if I can, that in our last set of facts on food insecurity that the Hamilton Project put out, well, something that we saw was that food insecurity, which used to be something really concentrated much more among very poor people, people who are eligible for SNAP, for WIC, for the school meals program, has spread up the income distribution in a quite alarming fashion, such that 2/3 of all food insecure families have incomes above poverty. This is a part of the income distribution that the safety net is not helping.
Right.
And what we need is job growth and wage growth.
So that to me is the harder solution.
That is harder,
because it's not like there are things out there that we sort of generally agree, yes, this is a 4-part strategy that's really going to pay high dividends.
I had a follow-up question to you. So you mentioned, safer cars, and you mentioned declines in smoking. Are there other technological solutions in the public health realm that are promising for the next 10, 20? Because it doesn't seem like we're winning the war on obesity.
The easiest thing in the public health world, the thing that we know very clearly, is that people respond to prices. So if you raise the price of tobacco, people smoke less. If you raise the price of alcohol, people drink less. If you raise the price of sugar-sweetened beverages, people drink fewer of them. So people are very, very responsive to prices. So if you can find a way to change the prices for obesity, which is sort of leveling off because we're increasing some of these prices and so on, then you can reduce that. And if you find a way to increase the price to people of opiate meds, currently they switch into heroin. If you find a way to increase the price of everything, people will find a way to switch out of them. So people are extremely responsive to prices, and they're also responsive to information when presented in a way they can handle it. So there's some forms of information that people will totally ignore, completely ignore about cigarettes, and there are other pieces of information that people will say, okay, this makes me really determined to try and quit next week. And it's things that,
Next week, yeah.
yeah, it's things that, and that really do get people to quit.
Yeah.
So it's things like, very subtle things that we kind of know behaviorally how to nudge people to do the right thing. I would say we're more confident in our knowledge of of the price impacts than of the other things. So if you said to me, what one thing would you do, that's where I would concentrate on. But I think there are things that we could do along this path.
And I guess we're starting to see real policy innovation in that. So Philadelphia just passed the large sugar sweetened beverage. Are there results in Berkeley yet?
I haven't seen any good convincing
Okay, so
results.
soon enough, we'll know more.
But if you look in kind of like, what happens when beverage prices increase, people clearly consume less of it. But also what I was saying, there are things you can do. If you point out the kind of immediate impact, so if I say to you, by the way, if you smoke, you'll die younger, nobody much cares, everybody vaguely knows that. If I show you a picture of someone who can't walk a block without oxygen and all of that and what it looks like, then people will decide they want to quit smoking. If you put signs in little grocery stores where, adolescents go saying, this big of a soda takes you 5 miles to walk it off, then people buy water. So you can sort of do smaller. We know of a bunch of things like that really seem to do well, that you could then say, okay, we're going to really run with that.
Gary.
It would be amazing if you had a panel containing this many researchers and none of them mentioned the possibility of doing more and better research. But I think Ann Case did mention specific kinds of comparisons that would shed light on the underlying sources of these trends. One thing that has always interested me is, how does the United States compare with other countries? I mean, has the income gradient of mortality difference risen in some other rich countries, even though, as we can see, in midlife, all of the other countries continue to have these improvements in mortality rates. But are there other countries that have this phenomenon in which there is an income gradient associated, so that some lower income people are not seeing improvements in lifespans, whereas higher income people are? I repeat, this news is not gloomy. If all you care about is your own longevity and you have high income, the evidence actually is very, very promising for you. And the question is, are there other countries that have at least some degree of this kind of trend? So I think that there's research that actually would help us decide where to put public policy dollars to improve the circumstances of lower income people.
Thanks. I've got a lot of really great questions from the audience, and they keep bringing more, so I'll weave those into some of my additional questions. But I think this one is partly from Mark McClellan, but anyone else. Do we have a sense of what evidence or information is needed to help providers help weigh the pros and cons of prescribing opioids?
There are better resources around for doing that, as well as other, I guess you'd call them, technological solutions, restricting access, prescription drug monitoring programs, and the like. I think, as David and Angus both said, though, healthcare a lot is often about episodic, brief encounters with patients who increasingly have chronic issues that are not easily dealt with in an episodic format. If it's a chronic pain issue or a mental illness issue, probably the most effective interventions are just of a different kind. And you can impose some restrictions on opioid prescribing, but I think the more promising approaches are ones that shift care to more of a team basis, especially for patients who are at risk for mental illness, depression, suicide, and the like. There are some successful models of doing it. It is hard, and it's not the way that most physicians are trained. It requires a different kind of financial structure where you're putting money into services that traditionally don't get reimbursed, like social workers or people out in the neighborhood who can just help make sure that patients are following up on treatment or sticking with their an effective substance abuse program. And that gets back to the big challenge a lot of healthcare providers are facing today. They'd like to do something about it. They feel pretty frustrated too in terms of what's coming into the emergency room or into their offices. And while there are some successful models of doing it differently, it requires approaching healthcare in a different way, and it requires paying for healthcare in a different way, and has some different expectations on patients as well about engaging not just with their doctor when they get sick, but being part of a system where their providers and they too are kind of accountable for taking healthcare in a new direction. I think that the optimistic thing for me is that this can be done. I mean, it is happening in places around the country. If you look at some of David's early work, I think future work that Ann talked about, we will hopefully find out more about what's happening in these communities that are doing well. I think the answer is not simply just expanding access to traditional health care. That didn't look very correlated with David's chart up there earlier. And what I think some of these reforms in healthcare are doing in the places where it's successful, and it'll be interesting to see if this plays out, is that you have more community engagement. You have pediatricians spending time with social workers, helping with early interventions in at-risk kids, or working with school nurses around preventing teen pregnancies, steps like that really do have longer-term outcome impacts. It's just hard to do in the way that we've financed and paid for healthcare up till now.
And you think that there are some, we know that we don't sort of do wholesale changes very often, but you think there are some incremental changes?
Yeah, I think there are plenty of examples
Congress
around the country of this happening. I think where there might be some bipartisan interest in Congress is in programs like Medicaid and social service programs to state and local levels. We're not going to, we're not saying that all this needs to be supported by block grants, but a shift from paying for traditional services to giving states or local communities more flexibility and some accountability along with it, to show that you're doing better on things like pre-K participation or kindergarten readiness or things like that. And that could really, I think, help provide some more supports for some of these programs that look like they're working in certain places but are really hard to do.
David Cutler, there's a question for you too. Sort of piggybacking on this, low-income areas are often rural with low access to care and services. Do we need a different way to tackle these problems in rural areas?
Yes, we do, although it turns out that the distinction between urban and rural is not the key one.
Is that right?
That's going on here. That is, when I tell you Tampa, Florida is doing very poorly, it's not because Tampa, Florida is a rural area. And so it's actually not particularly correlated with that. But yes, many of the things that one might think about, like, for example, the impacts of, let's say, local governments on making it very difficult to smoke. So in many big, higher income, upper middle income cities, it's virtually impossible to smoke indoors anywhere, which means that it's very difficult to smoke at all. So that's one likely reason why smoking rates are lower in those greener areas that I showed you, and why life expectancy is higher. Now, it's much more difficult to think about that kind of an intervention in a rural area because you're not doing it. So you're going to have to think about something else. What's interesting to me is that some of the public health interventions that have been successful have actually been quite successful in rural areas. So, for example, it's very difficult to have a fatal motor vehicle accident in Washington, D.C.
Sure.
So you're just never driving that fast. Whereas if you, in fact,
Really
you
not
may
fast at all.
really
That's true.
not
Yeah.
fast. Whereas in rural Virginia,
So Boston is
you can have a fatal motor vehicle accident, and if you look, the decline in fatal motor vehicle accidents will be much larger in rural areas than in urban areas. So so you can do it, you can reach there, but you probably need a different sort of strategy. That is the strategy of, hey, take the subway.
Yeah, not so good in rural areas.
It's great in Washington, D.C. It doesn't work.
Actually, it's
quite
not
as
so great in
well.
Washington, D.C.
Yes. Being from parochial Boston, it's an okay substitute. So you're just going to need to do it in different ways, and that may require different types of interactions between cities and rural areas, it may require different sorts of policies and other kinds of messaging.
So another common question is, people want us to talk a little bit more about the economics of despair and that hypothesis and things that we can possibly do. And so, for example, did free trade get us here? I would love any of the economists on the panel to respond to that.
Well, I think freer trade contributed to the trend in growing earnings disparities. There are things you can do to reduce the effects of growing pre-tax earnings disparities by shoring up the incomes at the bottom. One of the things that Barry and Kahn and I found, we tried to examine what has happened over the last 35 years by narrow age groups in the amount that inequality has risen. And what we find is that we started at about age 45. There's a much bigger increase in inequality in the middle of life. And once you get to age 62 and people can claim a Social Security pension, the gap between the bottom 10% and the middle income person just did not increase nearly as much as it did at younger ages, before people become entitled to really the most generous of the income distribution programs that the United States has. So past age 62, the growth in inequality was evident. It just was much, much smaller compared for the people under 62. And I think that is entirely traceable to things that economists, I think who've studied the income distribution, widely agree on, and that is earned income inequality that has made by far the biggest single contribution to the overall rise in income inequality. I know that many people are talking about capital in the 21st century and how capital inequality is contributing to overall inequality, and that's true. I don't deny that. It's just that from a practical standpoint, most of the population's income, especially the population under age 62, comes from labor earnings, and labor earnings inequality has risen quite a bit, and part of that rise is due to freer global markets that do make it possible to import things from very low-wage countries with very little impediment. I don't think it's the biggest single contributor to rising earnings inequality, and I don't think a lot of other sort of middle-of-the-road economists think it's the biggest single contributor, but it has contributed.
Anybody else want to make a defense of free trade? I think neither presidential candidate is in favor of it, so maybe it doesn't have any favor, or any love for that in this room.
Let me give you one. I have a quiz question, so I'm going to give you one more quiz question.
You got the first one wrong. Go ahead.
So people in New York live longer than people in Detroit. So that's true. Divide the population into thirds by income: upper third, middle third, lower third. In which thirds of the income distribution is the gap between New York and Detroit the highest?
Well, I know the answer because it's in our framing paper, but you all can guess. First, second, third?
No, the upper and the middle are virtually the same life expectancy in New York and Detroit. It's all in the bottom third. So it makes me suspect that what's going on here is probably not just a consequence of things like trade and the killing of the manufacturing industry, which has been a very big deal.
Because that's more middle.
Because that's much more in the middle class. Now, we do know from other work that when people are laid off, their health suffers. So it's very, very clear that people's health suffers when they're laid off. It's also clear that in a recession, people's health tends to improve a little bit, because they're spending less on tobacco and alcohol and things. So overall, I don't know enough to say for sure, but I'm somewhat skeptical that we can lay a lot of this at the feet of trade, free trade.
Yeah, I agree with that. Also, you always have to remember that free trade brings a lot of benefits too. I mean, we're getting a lot of really cheap stuff that we didn't used to get. and poor people benefit from that as well as rich people. I'm a little worried about these spatial comparisons, partly because for me, income has never really been the variable to look at here. And that's because income is deeply affected by whether you're sick or not. And if you look at the bottom of the income distribution, a lot of those people are disabled or they're out of the labor force and so on. So, thinking about it just from the causation running from income. I mean, David's never said this, and the paper doesn't say this, but nevertheless is always presented that way around, and that's the way your attention tends to go. But if you think of things like health insurance, for instance, better health insurance makes the gradient smaller, right? Because if you don't have health insurance and you get sick, it cleans you out financially too. And so it pushes you down to that bottom part of the income distribution. And so you maybe so better health insurance can have the effect of making those inequalities smaller, though it doesn't really seem obvious. Better unemployment insurance would have the same effect too, and we have lousy unemployment insurance compared with European countries, for instance. So that sort of stability would help work on the gradient. Health savings accounts are another example of something that propels the gradient upwards, because if you get sick, you lose money as well. And if you stay healthy, you gain money as well. So it's projecting these things out. So that's one of the things that when you look at this compared with other European countries, it's not quite so obvious how to do that, because there's so many of these other policies that are in there. The other thing I worry about is if you compare Detroit and New York, because when these life expectancies are calculated, you're holding people in the same income group all the time too. Now, I've talked about this with David and Raj, and they say, well, there's a limited amount of changing around in income groups. But that's not really true when you get sick, because you can lose your income as well as losing your health. And so when you look at these people at the bottom income distribution, they're not going to be there for the whole of the rest of their lives, or you hope they're not going to be there for the whole of their lives. And they may be there because they're in a temporary temporary episode of sickness. And so, it could be the difference between Detroit and New York is more to do with income mobility or how hard it is to get a job, which don't seem like they ought to be in the gradient, but they really are. And I don't have a very easy way to propose this. I mean, you can look at it all by education, but if you look at education across different European countries, that's a mess. Because the numbers of people in various education bins, the proportions are so different across different countries. And it's clear that high school education doesn't mean the same thing in Estonia from what it means in the US, for example. So these things are quite hard. And just coming back to what Gary said, I think there's a lot more room for good research in here. But it's not entirely, this is a really hard set of problems.
I just to add on to this point, I don't think it's what Angus was saying, but I'd be careful about the limits of health insurance and being able to address this problem. I mean, it is true that it can limit out-of-pocket spending after you get sick, but part of the underlying problems here, as you all pointed out, is that there's a kind of a cycle of this, of a higher risk of lots of health risks that health insurance is not, at least as we're doing health insurance and the health care that it buys now, is not really addressing. And the greater spending on health care that results from just plugging these gaps after they happen means probably fewer resources available to spend on things like job training program, early education programs, and things that could, I think if you asked a lot of the people in these groups, they'd probably rather have, especially for their kids, if they're looking downstream and thinking about the future, probably rather have spending on that.
Can I just make two observations? If my co-author Barry Bosworth is sitting in the room, he would probably be upset if I didn't make this point. When we look at the relationship between mid-career income and earnings and subsequent mortality experience, we're not simultaneously looking at someone's income. We're looking at their income at a fixed point in their life, and then over the following 30 years, seeing when they die. So it's not, we aren't removing this association that Angus talked about. And then second, we also replicate our findings almost exactly when we use relative educational attainment within, for people born in a given year. What was your position in the educational attainment distribution? And we get very similar results in terms of the implications for Social Security policy at any rate. In other words, we're trying to use things that are predetermined before we're measuring people's mortality experience. And I think, as I recall,
Not what they do.
It's 2 years before, right?
We
But
use,
that's not
Yeah,
the
it's not
issue.
enough, yeah.
No, it's not the issue. The issue is that it's this life expectancy business, which is if you do life expectancy by education, that's okay because your education doesn't change over time. But if you say someone at the bottom of the income distribution, what's the life expectancy, you're using percentile specific mortality rates at all points future. I mean, that's not the only way you could do it. I mean, you could build a transition matrix and have them
so we
move around.
we sort of explored that some, but the correlation between your percentile rank in 1 year and your percentile rank 10 years off is I can't remember, something like 0.7 or 0.8.
No, I'm sure that's right.
So
but
it just wasn't going to do anything to build, and even when it's different, it's not that.
it would be nice to
different.
have the
Yeah.
life expectancy figures calculated the other way.
Yeah.
Because your percentile has got to change when you retire, and it's got to change when you're sick. And you have those numbers. I mean, you have the transition probability, so you could run it all the way through.
Yeah,
I
Jim.
wanted to comment a little bit on this. The issue of mobility in income is also tied to the issue of hope. There's a lot of discussion of, are we losing the American dream, the right to rise? All of those tie to that. And if whether we think there's a lot or little mobility doesn't matter so much if the people in the midst of it feel differently. And that's part of what we are seeing, and if we're going to be responsive in a policy way, it's got to be responsive to those feelings, or that we do a better job of saying what's going on. I know that I've been the one who's been pushing a little bit on the kids. I'm going to comment a little bit on Social Security trustees. By 2030, there'll be 2 workers for everybody over 65, meaning on Medicare, perhaps on Social Security. It used to be we used to be 8 to 1, 11 to 1. Those workers in 2030 are all alive now. They've got to be well educated, have great jobs, and care about old people. We've got a lot of work ahead of us.
We do. I've got a bunch more questions, and I know we're sort of running short on time. One that I definitely want to raise, Mark, this is probably for you. So should hospitals and health systems be worried about these divergences in mortality rates? And if so, what should they do?
I think so. It means more people who have these serious health problems, probably more limited reimbursement despite Medicaid expansions. This is still a cost loss area for many hospitals and healthcare systems. And the other reason they should be worried about it is this is where all the money is going now. The kinds of resources that could be put into some of the other programs that we've heard about here today are going to these hospitals and health systems. So just from a standpoint of building a better community, that the more that they can do to invest those resources, to keep a focus on improving the health of their communities, the more we'll make progress on these issues. I mean, I do think that this community level focused work is very important. It's rebuilding some of the social ties and support networks that many of these individuals aren't feeling. This is not easy to do, but there is so much state, federal, local resources going into healthcare that if we don't rethink how we're doing that, it's going to be hard to make progress.
I have a couple more. One is, the trends in obesity and poor nutrition would suggest that maybe we should be seeing mortality rates look less good for populations that have high rates of obesity and stuff. How much has the increase in obesity and poor nutrition contributed to declines in mortality? I don't know if anybody has a good answer to that. David?
So a few different answers. One is, if you look over the past 20 years or so, the impact of rising obesity on life expectancy is a bit smaller, but not too much smaller than the impact of the reduction in smoking on longevity. So it's a pretty big issue. Now, that much said, The impact of obesity is probably falling over time because technologically we've developed ways to reduce its impact. So when Anne showed you the picture on cardiovascular heart disease mortality, I can't remember if it was the broader or the narrower category, one of the things that probably went through your mind is how can that be happening with the increase in obesity, since the one is a risk factor for the other? And the answer, at least part of it, is that we have many more preventive medications to prevent the heart attack that follows from the obesity. And the treatment in the course has gotten a lot better, too.
Lots better medical
Lots
treatments.
Aside what I understand
Despite
from
the
your
fact we're
work,
spending a
that's
lot
right.
on it, they do work.
And that has happened in the US as it has happened in other countries as well. So it's something where we've taken a social problem and come up with a technological solution to it, which, you know, you sort of, on the one hand, that's fine. On the other hand, you say, gosh, why didn't I just solve the darn social problem in the first place? I think for some of these others, what we've seen is we haven't been able to develop the technological solutions to them yet.
Jim?
I wanted to comment a little bit on that. David's right regarding longevity and mortality, but there's been real changes in the prevalence of diabetes, very costly. Treatable, manageable, but very costly. I trained as a pediatrician. I never saw a case of what used to be called adult onset diabetes as a pediatrician. Now about a third to half of the cases in children are type 2 adult onset diabetes. The most rapid ages of increase in diabetes diagnosis, 30s and 40s. So there is a huge cost and a wave coming. So we haven't seen the worst of it, but we are paying in the most expensive way for being able to manage these conditions. That's what I think Mark was going.
Thanks for bringing more depression back to this.
But if you're rich, you have nothing to worry about.
Actually, that's transitions. I would have loved to ask Angus this, but and I'm sorry that he's had to step off. Someone asked, I'm highly educated but low-income entrepreneur. In a horse race, which matters more? That I'm highly educated or that I've got a low income? I think it's a fair question. Of course, you know, we don't want to interpret any of these statistics about individual people because you could, there are lots of things that could happen. But is anybody?
Are we allowed to call
We can absolutely. Let's
call an Ann to.
Yep. Exactly. I think we've got good causal research on what happens with increased education. Is that right?
That's the hope issue.
Turn around.
So I could just repeat
around.
that for those of you who couldn't hear. Or you could do it again. Yep, Anne. With that, we have to close this. Thank you so much for joining us. Let's. Excellent.